I'd just like to get this event started. I'd like to thank you and welcome to the 2023 Tracy Maund Oration. My name is Stephen Lee and I'm the chair of the Royal Women's Hospital Senior Medical Staff Association. I'm honoured to be your host tonight. I'd like to begin by acknowledging that we are meeting on the lands of the Wurundjeri and Burunjung people of the Kulin Nation. I pay my respects to elders past and present, as well as to the elders and community members who may be present today. Before I introduce the speaker, I'd like to say a special thanks to the Women's Board member, Kim Parsons, our Chief Executive Officer, Sue Matthews, and members of the executive for being here tonight. I'd also like to thank attendees from other hospitals within the precinct for making the effort to be here. It's making this a truly precinct-wide event. Second lastly, I'd like to thank Vicky Carson, David Rader, Professor Leslie Rady for being here tonight. They're my predecessors and they've provided me with a lot of guidance throughout the years. And now lastly, I'd like to thank Georgia Metropolis and the Communications Department for helping me organise tonight and making this possible. So now, let's turn our attention to our speaker. We're very privileged to have Professor Karin Verspoor as our speaker for the 2023 Tracy Maund Oration. Professor Karin Verspoor is Executive Dean of the School of Computing Technologies at RMIT University. She's a Fellow of the Australasian Institute of Digital Health, a 2021 Brilliant Woman in Digital Health, and was selected as a finalist in Women in AI Australia New Zealand Awards 2022 for AI in Innovation. She's also a co-founder and the Victorian Node Lead of the Australian Alliance for Artificial Intelligence in Healthcare and a director of BioGrid Australia. Karin is passionate about using artificial intelligence to enable biological discovery and clinical decision support from data. Her work has a specific emphasis on the use of natural language processing to transform unstructured data in biomedicine into actionable information. This is very important these days. Karin held previous posts as Director of Health Technologies and Deputy Head of the School of Computing and Information Systems at the University of Melbourne, as the Scientific Director of Health and Life Sciences at NICTA Victoria Research Laboratory, at the University of Colorado School of Medicine, and at Los Alamos National Laboratory. She also spent 5 years in tech startups during the US tech bubble, where she helped design an early artificial intelligence system. Karin received a BA with a double major in computer science and cognitive sciences from Rice University in Texas, USA, and completed both a Master of Science and a PhD in cognitive science and natural language at the University of Edinburgh. Please offer your warmest welcome to Professor Verspoor.
Thank you so much. Thank you so much. I'm really happy to be here. And I have way too many slides in typical academic form, but you know, this is a topic where there's a lot to say. And I think it's actually really important for us to lay some foundations and some groundwork before I kind of get to the bigger ideas, because without that, we don't have a common language, and having a bit of common vocabulary is really important. Can you hear me okay? Oh, I have to hold it up higher. Okay, good. Okay, so we're going to be talking about the use of AI in the healthcare setting and thinking about opportunities and maybe also some things we need to be thinking about as we consider the adoption of AI. So we're going to start with what is artificial intelligence. Did I click through? Yeah, so this is the outline of the talk, so you can follow along. We're going to go through this structure. So we'll start with what is AI. Okay, there's a lot of hype out there these days. People are referring to AI in the first sense that I put up here, making machines intelligent, right? So this is the objective. The objective is to build a machine that is intelligent. I would suggest that actually what we're really doing in practice, and in fact maybe what our goal should be, is rather having the emphasis on artificial. So we're having a machine which can simulate the intelligence, but isn't in fact intelligent itself. And I think that's really important because if we start thinking about making machines intelligent and imbuing machines with intelligence, it opens up a whole heap of ethical questions and questions about our own humanness, our own humanity. When does a machine become conscious? I don't think the machines that we have today are anywhere near that, and so I just want to park that. But having this ambiguity out there actually makes it really challenging. So in the one case, machines are intelligent, and in the other case, machines appear intelligent. And I've been working, as you heard, for most of my career in trying to do the second part, right? To try to simulate the use of language in particular on machines. So what kinds of activities do we do with AI? Well, remember, it's about simulating human intelligence. And ultimately, most of these boil down to simulating things we do with our senses. So and our brains, of course. So obviously, we can't forget the brain. We have computer vision applications which try to simulate what we do with our eyes. We have speech recognition and audio processing systems that try to make sense of the sounds that are coming out of our mouths and the processing that our ears are doing. We have natural language processing, which is about making sense of words, which language is the key thing that makes us human. No other species on Earth has language, at least not in the kind of sophisticated way that we have language. So can we get a machine to make sense of it? Well, we can come back to that. We're trying to get machines to sense things through touch. So we have, we have sensors for heat. That's an obvious one. Pulse detectors, all sorts of things, right? Recognizing emotions, that's a really tricky one. And I'll come back to that in an example later. Learning is a key thing we do with our brain. We're constantly learning and evolving. Reasoning and planning, decision making, these are things we all do every day, all day long. And the more sophisticated our work is, clinical work is right up there in terms of abstract reasoning, the more difference there is between what we can do and what the machine can do. Okay, so there's a notion of narrow AI versus general AI. And I would propose that what you see in the world right now is pretty much limited to narrow AI. And I know people will argue with me that the generative AI, and if you've played with ChatGPT, that it seems to have these amazing capabilities. But it's actually quite limited in what it's doing. Okay, so we have AI that can solve very specific tasks. So you've probably heard that there are AI programs that can beat the world's best chess players or the world's best Go players. We have AI that is working on very specific disease diagnosis, so trying to use parameters from biometrics and things like that to diagnose disease. We have AI systems that are now modeling protein structures. So DeepMind released a system called AlphaFold last year, which is phenomenal at taking a protein sequence and predicting the three-dimensional structure of that sequence. Facial recognition, machine translation, and what I work on is information extraction, which is really about trying to find very specific kinds of information in text, including clinical text. What these systems can't really do yet is general AI, making sense of novel situations and communicating about them. So solving puzzles, new puzzles that we haven't seen before. That's very difficult for AI today. Hypothesis generation is very difficult because it requires combining many, many, many things together, although we are making some progress on that. Giving causal explanations for things, again, very difficult because the systems are not trying to understand why something happens, just understand that it happens. Meta-reasoning, semantics, entailment, common sense knowledge. ChatGPT does not know that if there's a hole in the ground, you might fall through it, and that you might hurt yourself. It can guess that the next word in the sequence is something like, oh, you're going to have a broken leg if you fall through that hole. But it also doesn't understand that if the hole is only this big, I'm not going to fall very far, and I'm probably not going to hurt myself. So there's lots of things that we know that are not captured in these systems, and they can't do. Okay, So machine learning, right? I said this is one thing that's really important. What is this all about? Ultimately, this is about taking data, running it through some algorithm, and then building a model. And that model, the purpose of the model is to take a question, again, a very narrow question typically, and to try to answer that question using the model. So we do that through various mechanisms. And one of the key and most successful mechanisms that we have is something called supervised learning. In supervised learning, we take pairs of data and answers for the particular question we're trying to solve for. And we give lots and lots and lots and lots and lots of examples of those pairs, right? So you have a known answer for a given piece of data. And the algorithm tries to infer essentially the associations between the patterns in the data and the answer. So that once we have that model, we can take new data that we haven't seen before, think new patient, and try to make a prediction about what the answer for the question would be for that patient. So that's the rough idea. So, the key thing to draw from this is that we rely on these pairs on the left-hand side. We need to have loads and loads and loads and loads and loads of examples of data-answer pairs in order to be able to build a model that's effective at prediction. Okay, where can we use this sort of thing? Well, arguably the most successful application of AI in the medical domain at the moment is in image classification. And so there's a whole number of these. But here's one example, is that if you give a bunch of images that have been labeled, say, yep, this is an example of a subdural hemorrhage, or no, and you run it through the model, then we want to take an image and ask the question, does this image contain a subdural hemorrhage? And the model should be able to say, yes, I recognize that, based on the patterns. Now, in this case, I cheated, and I used the same image over here that we have over here. So you would hope that the model would get it right, okay? But that's the basic idea. If we have a slightly different image, but still one that has the hemorrhage in it, can it make the prediction correctly? Now, these computer vision models in particular are very often based on deep learning, which is machine learning, but using a particular neural network architecture. And essentially, they're just massive, massive, massive mathematical compute structures. Okay, these things over here, that's some representation of the data. Remember, we have to start with data always. And then we just, we build these layers and layers of nodes, which don't really represent anything. So just think of them as little numbers. These are all just little numbers. And all the connections between the input and the first layer are weighted somehow. So each of these has some number attached to it. So we have numbers here, and we have numbers here, and we have numbers here and here. And all we do is literally just multiply. We just take the input. It's always represented as a number. We multiply. We do matrix multiplication. And at the end, we produce some output, which is based on the input. Now, I've put a bunch of outputs here because we often see these used to produce sequences of things. So if you take a text as input, you can produce a text as output. That's like the scenario for machine translation, for instance. You take a bunch of words on the input side, and you produce another bunch of words in a different language on the output side. And the trick here is that by running this calculation at very, 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 very many times, we're doing these nonlinear transformations of the data. And by driving it with the supervised signal, right, with the labels, with the answers, right, then we do that enough times, and the model basically learns how to set the weights on all of these links correctly, so that we get from the input to the desired output. Does that make sense? Okay. So the reason these things are so effective is because with all those layers, and remember, this is all just mathematical computation, all of that mathematical computation means that we can capture very complex features of the data. And typically what happens is the first layer captures some simple patterns in the data. The second, third, fourth, 10,000th layer captures increasingly sophisticated. So patterns that build on patterns that build on patterns. In an image, for instance, it might be the first layer just sort of detects where there are dark pixels and light pixels. And the second layer might detect where there are clusters of dark pixels versus light pixels. The third layer might detect a boundary between the dark and the light, and so on. Okay, whoop. You might have heard the term foundation models. So that has come out as a result of ChatGPT and things like this. And essentially, it's a deep learning model that has been exposed to a huge amount of data. And in the process, actually tries to capture very broad patterns within the data sets that are relevant to many tasks. And we have some evidence. We have foundation models for language. We also have them for images. If you've played with DALL-E or Midjourney, one of these systems, they're using a combination of image and text. Somehow they're trying to relate the input text to an image, but the key elements of the model are really visual. They're about the patterns within the data. So for language models, here's a little description. Parameters just means how many numbers are in the model, right? How many of those weights and nodes do we have? So the bigger, the deeper this deep learning model is, the more complex the task is that we can solve. And so we go from arithmetic to code completion and, proverbs. I don't know. I didn't make this. Google made this. But anyway, it's a nice picture somehow. OK. Oop. And then, of course, there's the generative models. And generative models are based on deep learning, which is a kind of machine learning. Particularly, the objective or the problem that they're trying to solve is to try to produce an output for a given input. And I said to you, yeah, they're probably not doing general AI, not solving general AI. And the reason that is because actually what the task of the system like GPT is to just predict the next word. That is literally all it is a next word predictor. So it takes the input, recite the first law of robotics, and says, right, what's the next word? A. OK, I've got recite the first law of robotics. A, now what? Robot. That is all it's doing. That is not intelligence. I hope you agree with me. OK, so that's the background. That's the context. What can we do with this stuff? Because it is very, it's just a bunch of mathematical transformations at the end of the day, right? And we just have a bunch of data. So, OK, why do we care? All right. Well, actually, I see many, many opportunities for AI in healthcare. And I thought I would start with the health services view, because this is kind of not the one that most people talk about. So most people talk about using data to make decisions, like the diagnosis, the decision that I gave you. But I would like to kind of think about how we can leverage the technology that exists today in ways that are actually useful today, perhaps, and maybe not as scary as some of the other uses of AI. Because, actually getting a computer to make decisions about patients is pretty scary, right? So, OK, how could we use it? Well, I don't know. I shouldn't say this because one of my treating physicians happens to be in the room. But the typical experience when you go to a clinician is that you walk in the room, they say hello to you, they make eye contact, you have a nice little conversation, and then they ask you a question. And as soon as you answer the question, they turn around, and they go to their computer, and they start typing. Now, as a patient, I mean, I'm a geek, nerd, sorry, we had this conversation earlier. I'm a nerd, so I kind of look over, and I'm like, what are you typing? And occasionally I find something interesting there. I just mentioned to Sue that I was actually born in West Africa. And I went to the GP once, and the GP says to me, where were you born? I said, Senegal. The GP turns around and types ethnicity, Senegalese. And I watched her type it, and I was like, no. Look at me. You've asked me the wrong question. Or at least you've written down the wrong thing, Anyway, so what if we, instead of having the clinician turn to the computer and break the eye contact, break that human communication that's so important in the clinical interaction, what if we just had an ambient listening device that would sit there and capture the conversation and maybe write down the notes for you? Wouldn't that be cool? I mean, you'd have to check it, okay? Don't trust it completely, but it would allow us to care for patients in a different way. Okay. I also think about the scenario where you have a patient that just doesn't understand English very well, and you, through no fault of your own, don't speak whatever their native language is very well. Imagine having an automated tool in there that could provide interpreting. I mean, we have human interpreters, but we all know they're in short supply, and they don't cover every language that's possible, right? But I even go further and say, can I have somebody who can translate doctor speak into normal human speak? Because, sorry, you guys use words that even smart people don't understand, right? So maybe we can have some sort of dynamic support that's context-specific that allows us to handle those sort of situations. Okay, I like language, so I could go on and on about these sorts of things. But let's talk about a few other examples that are not about direct clinical decision-making. We already have robots. Somebody mentioned it to me earlier. Stephen did. We already have robots that are helping to guide minimally invasive surgery. And the thing is that the robots can see things that we can't. And they can be very precise. And the human might be able to plan the surgery in advance, but then guide the robot. The AI can do some of that planning for us, potentially, because, again, it can be extremely precise and mathematical. Never gets tired. Didn't have a late night last night, all sorts of things. So potentially very, very valuable. We can use robots for patient monitoring. There's a lot of examples, especially during COVID, we saw a lot of this, machines going out to patients' homes, collecting information about them, and occasionally raising alerts. So maybe we can do that more effectively and have a little remote control center in the hospital that's actually monitoring patients that can't come in. We have robots that are now helping in aged care facilities, supporting social interaction, social engagement. And it sounds weird, I'm going to talk to my robot, but I have a Roomba, or a knockoff brand, and the thing has a name, right? And we talk to it like, no, don't bump into that. Oh, no, don't go there. Okay, shit, I need to turn you off. Anyway, there's something about having a machine that can still, even when we just don't have enough people around all the time. So sometimes we need the robots to provide us with care. So this is a great use of AI, why not? We're also using it in the context of actual service delivery. So trying to do inventory management, services demand prediction, scheduling. AI can help with this. Okay, so more from a research scientist perspective, we can also start thinking about using AI for things like clinical trials. How can we identify patients who are good candidates for a particular trial? How can we try to predict how well a trial will go? So basically, what's the chance of success of a trial? And there's a startup here in Melbourne called Opal.ai, which is trying to do exactly that by looking at examples of successful and unsuccessful clinical trials and trying to understand what the characteristics of those trials were. They're using machine learning. We're seeing increasing uses of AI in the context of drug design, target selection, and toxicity assessment. And again, some of my work relates to trying to support evidence-based medicine. What is evidence? Evidence is in the literature, right? That is our gold standard way of communicating what we know about how to treat our patients based on the research that has been done. Well, you guys use PubMed? There are 38 million articles indexed in PubMed. Good luck trying to read it all. So maybe we can use some AI to help us with this, right? And we're also doing some work around evidence assessment, so trying to assess the quality of the evidence that exists in that literature. Okay, but really we can use AI in many places across the clinical workflow environment, don't know what to call it exactly. So, I mean, we can use AI, personalized risk assessment. We see precision medicine being driven using AI, using data, patient communication, clinical decision support, trying to help understand, make a diagnosis what might be going on. Treatment selection, I think, is a really underappreciated area. Should I prescribe this drug or that one, and why? Like, what dosage should I use? Tailored medication prescribing, even smart data sharing. It sounds trivial, but knowing when to send a piece of information to a clinician or when to prompt a patient for something can actually be really, really helpful. And keeping in touch with patients. So, we all appreciate the automated text reminding us that our bills are due. Maybe there are more interesting ways that we can keep our patients engaged without necessarily draining our time. Okay, so those are some examples of how we can use AI. I would like to talk to you about something that's called real-world evidence, because this is where I see the real value coming in. And I want to give you a scenario. So the gold standard of medicine is evidence-based medicine. We make treatment decisions about our patients on the basis of randomized controlled trials that give us evidence for a particular choice. Now, these randomized controlled trials are always very narrowly defined, right? So in this example, we have a specific study on antipsychotics, and it defines these inclusion criteria. I thought you guys might like this one. Okay, males only. Okay, and the weight range for this study was within 20% of the ideal weight. Okay, so this person shows up. Not male, okay. Probably not within 20% of ideal. A little bit overweight. Okay, so this is your question. Do the results of the study apply to your patient? Do you know? I'm going to guess not. You're guessing, right? Well, sorry. You're using your experience and judgment to make a decision about whether those results apply to your patient. And in the absence of any other results, you're probably going to trust it, even though you're not really sure if it applies to your patient. Because we all want to do the right thing, right? Okay, so it's a tricky territory. And a lot of what we do in medicine, and not me, you, a lot of what is done in medicine is based on this kind of best case matching, right? It's sort of, kind of roughly the right information. And of course, we do set up best practice guidelines, which help us, and there are systematic reviews that can try to synthesize this. But at the end of the day, there's always going to be a gap between what we study in the research literature through randomized controlled trials and what we see in the actual population. So this particular study, once you applied all of these criteria, got us down to exactly 632 people who met, strictly speaking, the inclusion criteria from a population of 36,000. That's no good. And in general, if we look at the research literature, we have a lot of biases embedded in that literature. So 86% of clinical trial participants were white in 2014. I haven't looked for a new number. I'm sure it's not too much different. Studies mostly focus on males, so that study I gave you is no exception. Why is that? Well, females are disproportionately excluded, usually on secondary criteria such as being pregnant or being old. Because guess what? Women live longer. 79% of the genomic data that we have on the planet that we're basing all of our genetic testing on comes from white people, basically. European descent, okay? Even though they comprise only 16% of the world's population. One analysis that I found that looked at phase 2 and 3 RCTs, randomized controlled trials, in sleep medication, found that only 0.4% of the potential patients were actually eligible for the trial. So, the conclusion here is that we are doing medicine based on evidence which is not fit for purpose. So where are we going to get that fit for purpose evidence from? Okay, so randomized controlled trials are limited, and they have to be limited, okay? I'm not criticizing the randomized controlled trial paradigm. They have to be, because otherwise we cannot draw scientific conclusions from the samples, from the small sample sizes that we're able to study through a rigorous research methodology. But it means that we're always studying relatively healthy patients, right? They have exactly one thing wrong with them, whatever it is that we want to try to test for. So I ask you, what about everyone else? Okay, so maybe we can start looking at the data that we have and try to do some natural experiments and ask some of these questions about patients, about their outcomes, about their progress, through the lens of data. Where is this data coming from? Well, you all have Epic. Pretty cool. Ask Tim, I was like super excited when Epic finally got installed, especially because I work on text, right? So try to find, try to deal with a faxed document or even, a handwritten note. Heaven forbid. Okay, so, the electronic health record is a massive resource for us here, right? We have tons of information. I don't need to tell you what's in there because you use them a lot more than I do. But they're incredibly rich resources of data and across, a whole different levels of data. So we have obviously the administrative data, which we've had for a long time. So, we've had codes that were being produced at the end of a patient admission that were reported up to the Victorian government. But now we have much more in this category, right, of actual clinical documentation or laboratory results that you're collecting. My personal favorite, of course, is the text. We have notes. We have reasons for visits. We have histopathology reports. We have MRI reports. We have all daily progress notes from the nurses. We have all sorts of notes. So that creates a new AI problem, which is to make sense of all of that language, right? Data that's in there. Unstructured data, by the way, also technically includes images, because images are not structured in the sense that we know exactly what they tell us, right? We have to do some work to transform them. Okay, so how might we do this differently? Okay, we have all this data. We can put it on a timeline. We can transform the data into essentially events. And we can say, all right, there was a procedure at this time and so on. Drugs were administered at this time and that time. Measurements were taken, conditions were documented, et cetera. Okay, so we have some kind of treatment, and then later there is some kind of outcome, right? And we have the context of a disease. So if we take this kind of view of the electronic health record, then we can start thinking about applying statistics and ultimately machine learning to try to model what's in that data. So we can produce knowledge actually by asking questions of the data. So which treatments did patients choose after a given diagnosis? Which patients chose which treatments? I'm assuming you're giving your patients some choice here, so I hope that's okay. How many patients experience a particular outcome after being given that treatment? Does the treatment cause an outcome? Okay, so these are questions you can just count, right? You can basically just read that off the data. This one is harder. Does treatment cause an outcome? We have to try to make some association between the treatment and the outcome. And maybe interestingly, we can do kind of in situ control experiments where we compare one particular outcome with an alternative and look at the probabilities there. And interestingly, we can go down to the individual patient level. So we can start modeling this data and try to understand for a patient with a particular set of events, what's the probability that they will develop a disease at some point or experience a particular different kind of outcome. So we can leverage the electronic health record as a resource to test scenarios. across the population. Now, obviously, this means we need a lot of data, and at least we've got 4 hospitals here that are sharing data, which is a good start. I would suggest that to get any meaningful individual level predictive patterns, we're going to need to have something much bigger. And wouldn't it be cool if we had a national electronic health record system? But anyway, okay, so why do we care? Because ultimately we want to help inform decisions, right? What test should I order next? What's the likelihood that my patient will develop a particular condition? What treatment should I choose? And should I let them go home? All of these decisions involve making a prediction. We're trying to guess what's going to happen next. And depending on what that prediction is, that will inform the decision. So ultimately, we come back to that paradigm of using the data to infer a model that allows us to answer a question. Okay, so this is just another kind of view of this. We can have clinical questions. Maybe at the patient level, will I have another seizure? We can have a model which tells us, yes, the probability of you having a seizure is higher than not. And the clinical outcome or the clinical value of that is that it can help to increase the certainty of the diagnosis, and so on. So we can use the data to help us make decisions. Okay, so why aren't we doing this today? Well, at least partly because we don't have enough data, right? There's too much variability in the populations. But there are also some challenges that we might need to talk about. Okay, so first of all, just to sum it up, AI is not medical grade. That's how I would phrase it. It's probably the easiest way to put it. And that's because there's still a lot of unknowns in how we're building these models, how we're evaluating these models, and we're not really sure if we should trust them yet. And I think part of this is that, anytime you have a system that's based on leveraging data, you have to have some confidence that that data is not biased. Because if the data is biased, then your model will be biased. So, the people who are nerdy like me might have heard of garbage in, garbage out. Well, bias in, bias out. If there's bias in our data, there's going to be bias in our models. Then we have a problem like data drift. Oh, so by the way, I frame this as who is the data, because a lot of times you get data geeks like me, and they'll just ask you, so what data do you have? What data do you have? And they'll talk to you about those procedures and those drugs and so on. But we have to remember, these are people. That data represents people. And that's the important thing, is we need to remember that those people vary a lot. Not just their data. Their data varies, but the people vary more. Okay, so we also have data drift. So over time, populations change, things change. You get COVID, pandemics racing through. The context changes. And so if you have a model that was based on historical data and you're trying to bring it and use it today, what has changed? How has the model changed? It doesn't, because once you built the model's there. So how can we accommodate for change? How do things generalize? So we tend to build, because it's hard to get access to clinical data and it's hard to share, we're not good at sharing this data, we tend to build models in one place and then try to use them somewhere else. And the problem is that the differences in the data environments, as well as the patient populations, can mean that the model really, really doesn't work in the new context. For many different reasons, right? But this is a problem. How well do our models generalize? How easily can we move them from one context to another? I won't talk about hallucinations because that's not so relevant for prediction, but it's something we need to be aware of if we're going to use AI in other contexts, right? And one of the key things is that even the way we build and evaluate machine learning models is that it's based on aggregate performance rather than stratified performance. And so this creates issues for us when we think about what it is that we would like to apply to an individual. So if our aggregate, if we have bias, then our aggregate evaluations will not represent the subgroups. So I've got a few trans people in here. They're not represented effectively in our data sets. So no model will ever have been really tested on that particular subpopulation, right? So, and you can extrapolate out to any kind of subpopulation you want to talk about, but that basic idea of we evaluate on the majority, by definition, right? We're counting how many times we get the answer right. Well, if the population in the test data is skewed one way versus another, then we're not really evaluating on those subpopulations. Okay, so we have some barriers. Clinical data is sensitive. It's hard to access. That's the reason why we can't build big models using big data. And no, 50,000 admissions a year is not big data. Okay, not when you're talking about massive populations. It's nice, it's great, it's good data, but it's not big data. And there are good reasons for it, no question. And so I think, as a computer science community, we need to be asking ourselves, how can we develop privacy-preserving approaches to doing machine learning in this context? And I have a grant on that, so hey, stay tuned. A few years from now, I might have some answers. Other people are working on it too, of course. Anyway, and like, you think about the My Health record, opt in, opt out. Who opts out? The people who are worried about their privacy. Often that correlates very strongly with people who are in very sensitive groups. And those are exactly the people we want to be in the data, because otherwise how can we address their problems? And so we need to really think about that. It's critical to incorporate these underrepresented or marginalized groups, but we need to protect them. So we need to somehow do it. Then, of course, there's the technical support for installing these systems in the hospitals that's often quite lacking. We can build a cool tool, we can prove that it works well, hopefully in a not too biased data set, and then what? It sits there, we get a research publication, yay, but what's the value? And we need you all, right? Remember all those labels? We need the clinicians to tell us what's relevant, what it is that is interesting to capture in the data, so that we can drive that whole machine learning process. And you know what? You guys are hard to pin down. I got some friends in the room who help me out from time to time, but okay, that's because they're nice people. And apparently their children don't mind not seeing them. Anyway, okay, and challenges in terms of modeling are that the data itself is very variable, and that different amounts of data are collected for different patients. All the patterns of interaction with the healthcare system vary hugely. For a regional patient versus a city-based patient. Obviously, we have just lots of individual variation at a genetic level, but we also have variation at an exposure level or at a risk factor level, family history, right? Data quality itself, capturing the data is variable. There are different standards in different places. And we just have a lot of missing data. So there's things that don't get captured in the data, or don't get captured, always the same way for the same two people. And we are right now thinking about just those clinical data sets, but actually we need to start doing some cross integration of data. So we can't just look at electronic health record data in isolation of genomic data. We need to bring those things together because one influences the other. Same with environment, same with behavioral factors, lifestyle factors, and so on. And we have data at completely different timescales. So, my Apple Watch can track my steps, it can track my heart rate, it can tell me that I'm getting nervous. Your heart rate is high. Oh shit, I'm breathing. I can get that data 24/7. How does that relate? How do we even mathematically connect 24/7 data source with a once a quarter office visit? They're just at different scales, right? So these are all challenges. And do we trust these systems? This is a big question. Honestly, until ChatGPT, every clinician I ever spoke to was like, nope, no AI. AI, not going to be, nope, don't trust it. Unless it can explain the prediction that it's given, I don't want to know about it. ChatGPT changed everything. All of a sudden, we're like, hey, look, it can talk to us. I understand it. Cool. Nobody questions how it works. I haven't heard the word explanation since November last year. They're like, look how cool it is. It's so amazing. It produces all this beautiful language. Yeah, that's fine. Okay. And arguably, I don't think we actually need the AI to be able to explain every decision. But we need to trust it. And that comes back to evaluation. That comes back to understanding the data that the system was based on. And it means that we need that we have to have some rigor and regulation around these systems. Because you don't want to be making a decision with a system that you don't really trust. That's a complete black box, first of all, but second of all, that you don't know how it was designed, developed, and evaluated. Okay, I've already said this. We need to be thinking about how we can transfer things from one context to another. Sometimes that might mean we need to do some what's called fine-tuning, so try to adapt the model to the local context. Okay, so what can go wrong? Well, errors are not randomly distributed. We know from facial recognition technology, for instance, that they do a far better job of seeing white men than they do dark-skinned women. And in fact, women are lower than men, and dark men, depends on which tool you use, might be better or worse than light women, and dark women forget about it. So there's a very famous researcher at MIT who became famous because she basically showed that the facial recognition technology did not see her, literally. Like it could, no, it wasn't about recognizing her. It was about the fact that she's African. And it just, the systems had no data about black people. Crazy. These biases can worsen over time. There's examples from police surveillance using AI where, there's a little phenomenon. If you find crime and you tell the AI to pay more attention to those areas to find crime, you find more crime. And then guess what? You find even more crime. And so the disparities between the populations can actually worsen because of the way we're deploying the technology. The technology itself is not becoming more biased. It's our use of it. Here's a fun one. I remember I said emotion detection. Okay, so somebody decided to create this personality machine, and I hope it was a research project, but the idea was that you would, put your picture there, and it would tell you how open you are and how extroverted and how agreeable. You can imagine some company using this to screen, right? Like, oh, do we want to hire this person? Nah, they don't seem very agreeable. They're kind of neurotic, so nah. Okay, so this study, what they showed is that if you just change the contrast and the brightness a little bit, you just play around with those little filters down at the bottom, that changes the output of the model. Oops. So these are the kinds of things that can go wrong, right? Because spurious factors in the data can get picked up as important by the model because remember, all it's doing is maths. It's just trying to relate, the pixels and the characteristics and features of the data to an outcome. I'm not really sure where they got the data for this in the first place, but anyway. Just ChatGPT for one instant because, you have to talk about ChatGPT. Create a treatment plan for a patient in acute pulmonary edema. Now, I did this back in March, and they're always fiddling, so I think it's better now. But at the time, what did it tell me? Okay, 1, go to the emergency room. 2, run some tests. 3, prescribe some drugs. I was like, well, hang on a second. I mean, I'm not a doctor, but I kind of, the presupposition of this question is I have a patient. I don't need to send them anywhere. They're there, right? They're in acute pulmonary edema. Okay, so I don't need to run some tests because I already know this. So why are you telling me to run some tests? So, okay, no, thank you. No, thank you. And then we get to, okay, the thing I actually care about. Medications may be prescribed to relieve symptoms. Thank you. Very helpful, ChatGPT. Okay, so it's really, I was not impressed. I think it has ways to go. Okay, I mentioned regulation. So one key thing to know is that the TGA is on this, of course, and they're trying to think about how we can regulate not just software, but AI software specifically. But it's interesting because they have this little workflow, and really the critical question is that, and the only thing they care about is whether these systems are intended to replace clinical judgment. Now, I think there's a lot of gray area here, and I think there's a lot of people building AI systems that would argue a case that they're not trying to replace clinical judgment. No, we're just trying to help. Where do we draw that line? So I think we need to be thinking about that. Okay. All right. But we should persevere, right? Because we do have some really, really, really good examples of where AI is already helping us. And as I said, the most successful applications are in image processing. So we have fantastic examples of systems that can look at skin lesions and determine whether they're cancerous or not, that can look at breast scans, and we have Dr. Helen Fraser, who won the Women in AI Big Award. So I was just a finalist in one category. She won the overall award because she's working with Breast Screen Victoria on using AI in breast screening. We have all sorts of examples. I have a student who's been working on corneal scans. There's a whole bunch of places where we can leverage AI, because here's the nice thing about images. They come off of a machine. It's manufactured by a handful of manufacturers globally, very consistent outputs. Obviously, there's some dependency on the technician that takes the images, but it's a nice N by M matrix, right? So it's a good mathematical object that's produced out of the image, and it just lends itself really, really well to the analysis. So great. So more image processing, please. Good. But we're also seeing success in trying to do things like fraud detection. I mentioned inventory management, the robots, and remote patient care. All of these things are happening already and are working quite well. We're moving towards what are called clinical foundation models. And so, building on kind of what we hear about in these large language models like ChatGPT, we're trying to do that in a way that's tailored to the language of the clinical context, and ultimately use all that patient medical history to build a mathematical representation of the data. So either the text that we have or all of those other great things we're capturing in our electronic health record system. And we can use them in a generative way, maybe to help you write a discharge summary. Be careful. But probably, from my perspective, more interestingly, is to encode all of the information that's in those texts into a representation that we can then use for downstream tasks like prediction. So back to the real-world evidence kind of scenario. And it's a similar thing for the medical history stuff. So we don't necessarily, need to do generative stuff in order for AI to be useful. And in fact, we've been using natural language processing in the context of electronic health records for various things. So this is work that came out of Stanford and Google, a Stanford-Google collaboration where this was published a while ago, 2018, where they showed that they could do prediction on a range of tasks quite accurately by modeling the data in the electronic health record. And one of my students he wrote his PhD on essentially trying to leverage the text in the electronic health record, sadly not with any Melbourne-based data, US-based data, because that's all we can get our hands on. But we're using it to try to do early prediction of diagnostic-related groups. You all know about DRGs, I assume. So basically using 24 hours or 48 hours of admission data, trying to predict what the eventual DRG will be and what the cost will be, the cost of care will be. Now, do you want to use that directly in clinical care? I think we need to be a little careful. Some ethical issues, maybe. Like, what do you do if you figure out that your patient's going to have 1 million problems, right, at risk for a huge, expensive surgery? Okay, we might need to think about how we use this information, but certainly from an operational perspective, it's valuable to know that we might need so many beds and so many surgeons and so on. Okay. the thing I'm excited about is this notion of patients like mine, where we can leverage the data to basically find patterns that relate our patients together. And we can organize the data using this kind of, mathematical representation so that we can find clusters of people. And, we might, in some cases, prefer to group all the women together and all the men together, but in other cases, we'll have different reasons that they're connected or similar, right? And so then, if we get our patient coming in, and we don't quite know what to do with this patient, we can say, okay, who is my patient most like, right? Patients like mine. Find the other patients that are similar to my patient and tell me what happened with them. This might be an interesting way to help inform some of the decision making. Okay, but we should be asking, what are we trying to achieve, and what do patients want? And where do we draw the lines between all these different options of integrating AI in various ways? Do we need to be moving towards having a conversation with this system? Why did you recommend this and not that? And I think it's really important that you're all here and learning about this, and that the next generation of our medical workforce needs to understand this technology at least enough so that they know when it's there and what can go wrong. Because we need to be able to mitigate. There's always going to be some error rate. So we need to be able to be prepared for that. Okay. So I think about this notion of AI augmented clinical decision making. And there was a guy named Chuck Friedman who published this Friedman's fundamental theorem of informatics in 2009. And he said, a person working in partnership with an information resource like an electronic health record is better than that same person unassisted. And he argued his case. Well, I would like to propose a variant of the Friedman theorem of informatics to say a person working in partnership with an AI is better than that same person unassisted. Now, obviously, I think humans are better than AI, no question. But I do think that using AI has the potential to help you all be better humans, or at least be better clinical decision makers, okay? And how do I see this happening? I think a lot of what we're trying to do in AI is like a big monolithic thing, right? We're taking all of the data and trying to make that prediction. And there's no use of context, there's no nuance, it's just data in, decision out. Why don't we have little micro tasks that are aligned to the kinds of information? Stephen was telling me earlier, it was so cool because I could learn about, he did a certificate or diploma in informatics, IT. He's like, thinking about how you can use the data. You want to use information, right, in your clinical decision making. Like, I want this little piece of information. You guys are like detectives, right? Find these little bits of information, you put it all together into a picture. Well, maybe we can have some AIs, some mini AIs, not the big AI, but we can have a bunch of mini AIs that help us, that surface the information that's relevant to the decision. And so here's a little example of a discharge decision. Maybe you need to know, do they have social support at home? How can we get that? Well, I'll give you an example in a second. Have they had an adverse drug reaction? Is there evidence of infection? What's the trajectory of the signs and symptoms been over the last few days? How are they eating? We can build little mini AIs that address each of these smaller problems and leave the big decision to the really intelligent one. Yeah? Okay, so little example of how this might work. So in our nurse's notes, we have this. The patient's brother visited. We have the patient's brother was sitting. The mother was waiting. Coffee with sister. All of these things, if we want to ask the question of whether our patient has social support, that's a pretty good clue, right? There are 4 instances of visits. Somebody's coming to visit the patient. That's a good sign that they're going to get help. Okay. All right, and I just wanted to throw out there, because all this has been quite generic, that there is, in fact, increasing, thankfully, attention to women's health. And it is starting in the image space. So I mentioned Helen and her work with Breast Cream Victoria. That's happening. There's a company Precigen, I think is the name of the company, that has this product called Life Whisperer, which tries to use computer vision to assess the viability of embryos, do embryo selection. There are uses of AI on fetal ultrasounds, trying to look for abnormalities. But, you know, always a cautionary note. It's still work in progress. We need to be thinking about it. A few years ago, during COVID, because, you know, what else do you do when you're bored at home during COVID? We decided to run a special session at a conference on big data analytics in women's health. See, my name's there, I did it. I haven't done much work in this area, but we tried to kind of stimulate some of that work. And guess what? All the names here are women. Why is it that only women care about women? Strange. Anyway, so we ran this session at a conference, and we got a couple of interesting papers. One, which is looking at radiology reports, so looking at the text associated with images, intimate partner violence, and injury prediction. Here was another one, investigating emergency versus elective C-section deliveries as an adverse pregnancy outcome, so trying to model the data around delivery. And I just saw this today, this morning. This comes in my inbox. A digital tool may improve menopause care. Now, I don't know if there's AI in this, but I'm going to guess there probably is somewhere, at least some kind of machine learning. And what are they trying to do? Prescribe hormone replacement therapy in menopause. That's good. We don't have a lot that helps with menopause care, do we? Okay, so I'm going to stop there. What are the conclusions? I hope I have convinced you that we have potential here, right? That AI might be able to improve our clinical interactions at least, but also enhance clinical care. That AI can help support the generation of evidence from real-world data rather than from these contrived clinical trials. AI can help us find and infer and utilize data to support your decision-making, hopefully not entirely replace it. But there's still work to be done, yeah? So we need more evidence about the clinical value of these tools and just at a technical level, their robustness and their applicability. So I will leave it there, and I'm happy to answer any questions you might have.